Hello, my name is Larry Reynolds. It is December 9th, 2019. I'll be presenting today on, this is my second presentation for this class, and I'll be presenting on a condition called acute respiratory distress syndrome. I have my little reference card here that I'll be referring to periodically throughout the presentation. So let's get started. Acute respiratory distress syndrome, or ARDS, or ARDS, it might be referred to from time to time, is an acute, life-threatening disease of the lungs, and specifically the lung tissues themselves, that's secondary to, so brought on by some other mechanism. Those mechanisms can include things like smoke inhalation, so people in a burning building can't get out, they're stuck breathing hot gas and hot smoke. That can lead to ARDS. Respiratory infections, so severe respiratory infections like severe pneumonia, sepsis, things like that can lead to ARDS. Radiation, so severe radiation burns, chest trauma, blunt force chest trauma can lead to pulmonary contusions and widespread lung damage, lung tissue damage, which can lead to ARDS, and then other things similar to that. Anything really that can damage the lining of the lungs and the lining of the alveolar sac specifically. So what happens with ARDS is that initial insult to the lungs damages the epithelial lining of the alveolar sacs within the lungs, the place where gas exchange happens in the lungs. And what happens is those vessels become leaky, inflammation sets in, and the insult is twofold, because that inflammation causes a decrease in the ability for gas exchange to occur, and then the damage to the lining itself decreases the amount of gas exchange that can occur as well. So we see decreased lung compliance, so it's difficult to breathe, difficult to bag a patient in ARDS, and then also, if you can, that gas exchange, it has no way to cross the barrier because the barrier is damaged within the lungs and can't get into the blood. Clinical manifestations, so these signs and symptoms, so you have sudden onset, generally sudden onset, shortness of breath, decreased levels of oxygen in the blood, so hypoxia, hypoxemia, decreased SpO2, dyspnea, and altered mental status from the hypoxia and things like that. These symptoms generally occur 12 to 18 hours or so after the initial insult. At least the sudden onset of the severity of the symptoms happens around that time, 12 to 18 hours, 12 to 24 hours after the initial insult. And the reason for that is because it takes time for that inflammation really to set in, and for that damage to kind of become almost finalized, for lack of a better word, within the lung tissues, within the alveolar sacs. Clinical differentials, I picked three. So there are three other lung problems, other lung conditions or disorders or diseases that kind of can present similarly, but aren't quite the same as ARDS. Some of them can lead to ARDS, but aren't exactly the same, and they're treated differently. The first is pneumonia. Pneumonia, like I said earlier, can lead to or cause ARDS, but it's treated differently and it presents somewhat differently. You may have similar lung sounds with pneumonia as you would with ARDS, kind of coarse, crackly, or diminished lung sounds. Excuse me. But it's generally unilateral, meaning it only affects one lung. And you'll see that on a chest x-ray as well. Chest x-ray will show, with pneumonia, will show unilateral infiltrates usually, whereas ARDS, which is more diffuse and affects all areas of both lungs, will show infiltrates in both lungs, usually all areas of both lungs. And so that's how you rule that out. It's treated differently as well. Pneumonia is treated with antibiotics. A person in ARDS may be on antibiotics, but it's not generally treated. Antibiotics aren't aren't indicated for ARDS specifically itself. The next condition to rule out if you're suspecting ARDS would be the presence of a pneumo or hemothorax. And so similarly to pneumonia, it will show up differently on a chest X-ray. You'll have usually unilateral, but not always, unilateral collapsed lung. Kind of depends on the mechanism, but it'll show a collapsed lung on chest X-ray versus infiltrates bilaterally. You'll have diminished lung sounds on whichever side is affected by the pneumothorax or hemothorax, and then it's treated differently. The hemopneumo would be treated with a chest tube usually if it's bad enough. And then finally, COPD. COPD is not. It presents a little bit differently. From ARDS, because it's more of a chronic disorder. The patient is often oxygen dependent. He or she will require oxygen, but lung sounds will be diminished, but more, you'll hear rhonchi, you'll hear tight lung sounds, wheezy lung sounds, and it's treated with bronchodilators and steroids, whereas ARDS is treated differently, which we'll get to in just a moment. Three associated diseases that are associated with ARDS. The first is shock, and the shock can present. There can be different types of shock depending on the initial mechanism, the initial insult. You can have septic shock, you can have distributive shock, cardiogenic shock. It kind of depends on what the initial insult was. And then you'll treat the shock as it presents. And then multi-organ failure or multi-system organ failure is the second that I chose, and basically the lungs are where gas exchange occurs, and if that gas exchange does not occur, the rest of your body, really every organ system in your body, will be affected in some way, usually drastically. So your central nervous system will be affected, your cardiovascular system, your renal system, your kidneys will begin to shut down pretty quickly. Your GI system will be affected. If your lungs aren't working, you don't have that gas exchange, then your organs will shut down quickly, and they'll be drastically affected by that. And then, cardiopulmonary collapse or cardiopulmonary arrest, if not treated quickly, is a third associated disease or dysfunction disorder. Obviously, if you don't treat the patient quickly and get the respiratory status back up to par to what the body requires, your heart will begin to shut down. It will collapse. Your cardiovascular system will collapse, and of course your lungs they've already been compromised, but they'll shut down as well. Various treatments. It kind of depends on the severity of the condition of ARDS, but generally, if a patient is in acute, severe enough ARDS, we treat them obviously high levels of oxygen, and then we secure their airway. We treat the initial cause as best we can, if we can. So if it's secondary to sepsis, we'll high dose broad spectrum antibiotics, and so forth. So usually ARDS requires some sort of airway management. So we'll intubation and secure that airway, and there are different levels, different types of vent settings indicated for ARDS. The most common that I've seen, it's called bivents, what is high levels of FiO2, high levels of oxygen delivery to the patient, and then high level of what's called PEEP, so percent of expiratory pressure, and that basically keeps those lungs open, and then high inspiratory volume or inspiratory time and low expiratory time. So setting seen often is called bivent. And so that has a very high PEEP, and high I time, high inspiratory time, and a very short, quick, low expiratory time. And what that does is it does two things. One is it keeps the lungs open for much longer than what would normally be seen in regular respiration. Keeps them open longer, takes a long breath in, short, quick breath out, and never really lets the lungs collapse, I guess, or it never really lets the lungs, the alveolar sacs collapse, keeps them open. And then if all else fails, excuse me, if the ventilator is still not doing its job, we're still having a hard time keeping the body's oxygen demands and respiratory requirements up to par, the last ditch effort is called VV ECMO, extracorporeal oxygen membrane oxygenation, veno-venous ECMO. And so what that does is basically a large bore cannula is placed usually in the patient's neck or groin, and it pulls blood from the patient into a machine that basically oxygenates and pulls CO2 off of the blood and introduces oxygen into the blood and then puts it back in the patient. Basically, it takes over the job of the lungs, and the lungs don't have to do any work until they have time to heal. And that's kind of a last-ditch effort. It's generally reserved for people who have no other option for a quick recovery, but all they really need is some time for the lungs to heal, and that's what VV ECMO does. It just basically buys time to allow the lungs to heal, and once they do, they'll be taken off ECMO, and the lungs will start doing their thing again and start working properly. Excuse me. That's all I have. I hope you found this entertaining and educational. Thank you for taking the time to listen. Have a good day and a Merry Christmas.